So thanks everybody for joining us today. I have the great pleasure of welcoming back Dr. Ken Margulies, who's joining us from University of Pennsylvania. Dr. Margulies today, previously he presented a great lecture on the physiology of the cardiac myocyte. And today he's going to be talking about the flip side of that coin, the pathophysiology of heart failure. So Dr. Margulies, thanks again, and we look forward to seeing what you have to share with us today.
Great. Glad to be here. I'm going to get right into it. It's a big topic. I want to begin with a disclaimer that many of the topics within this are things people have devoted their entire careers to. So by definition, this is going to be an overview of those key concepts. Admit them. Let's go. Okay, so let's start with some learning objectives as highlighted here. Myocardial remodeling in one facet or another will take up most of this, and it's important to recognize key features and relevant distinctions among types of pathologic cardiac remodeling. I think that'll be possible at the end of this. Appreciate that both biomechanical and neurohormonal contributors are quite prominent bases for myocardial remodeling. Understand that mechanical dyssynchrony at the organ level can trigger both less efficient pump function and at that organ level, but at the same time, induce pathologic cellular remodeling. Recognize how the basic architecture common to most signaling pathways, which can be often quite confusing, it can be sort of distilled down into elements that are maybe less confusing and produce coordinated adaptations to pathologic stress. And some of these coordinated adaptations echo developmental processes in something we call the fetal gene program. I'll have a bit about that. And understand the various intracellular and extracellular contributors to increase myocardial stiffness towards the end here. So let's get on with it. So the first is why we care about myocardial remodeling. The most important reason is it has a lot to do with outcomes. It's strongly related to death after myocardial infarction, as highlighted in some of these manuscripts here: death in idiopathic dilated cardiomyopathy, death in the general population, as in from Framingham. And on the flip side, regression of pathologic remodeling is associated with favorable outcomes regardless of how it's achieved. So it's something we should be pursuing. It's become part of our guidelines that we're looking for a reverse remodeling or whatever you want to call it. It's something to be pursued. And fortunately, many of our therapies have the capacity to do that. So this is a picture from a classic slide published by my former colleagues, Mariel Jessup and Sue Brzezina, published in the New England Journal more than 2 decades ago, but it's still relevant. We see that after an initial insult, let's take on the top a myocardial infarction, an apical MI, that we might see no immediate effect on the shape of the overall left ventricle, but then within a short amount of time, we begin to see a process called expansion of the infarct, and then later, months usually, or even years, we start seeing global remodeling, where the whole heart chamber dilates, the area that was infarcted thins, and even the other walls tend to thin to some degree as the chamber gets more distended. We also see ventricular remodeling in non-ischemic cardiomyopathies, whether it's we see a normal heart for comparison shown on the bottom left, and then in hypertrophied hearts that you might see with a hypertrophic cardiomyopathy gene variant, or you get thickened walls and no real change in chamber dimensions, or a dilated heart with either genetic or other causes of non-ischemic cardiomyopathy, where the chamber enlarges, the wall tends to thin, and certainly the relative wall thickness is dropping quite a lot. And that has implications for myocardial wall stress, which we'll discuss in a bit. So I want to then consider what are the different determinants of myocardial remodeling. And I'll have a few different slides like this. This is a very old one we made a long time ago, but the idea is that many different factors have been proven to be contributors to the dynamics of myocardial remodeling. Some of them are patient-related factors, host factors. It can be the host genetics, as I just showed in those hypertrophied and dilated cardiomyopathy cartoons. It can be people's comorbidities. It can be whether they adhere or not adhere to the therapies we prescribe. Age itself is a remodeling factor. Other things that I'll talk about quite a lot is biomechanical or hemodynamic overload, things like hypertension, MI, of course, even even myocardial or even things like dyssynchrony result in a hemodynamic overload. We'll get back to that. And then another thing I'll spend a good deal of time talking about is neurohormonal factors, whether it's catecholamines, angiotensin, endothelin, inflammatory cytokines. All of these have been demonstrated to contribute to myocardial remodeling, either alone or in combination with other factors. And the reason we care about this is that there's clinical consequences of myocardial remodeling, not only the outcome studies that I highlighted on a previous slide, but also specific things, right? That makes you basically myocardial remodeling, pathologic remodeling makes more prone to myocardial ischemia because some of the remodeling is even in the microvasculature. There's congestive heart failure due to impaired contractility, impaired LV filling, or both. And ventricular dysrhythmias also track with myocardial remodeling, and so do atrial arrhythmias for that matter. Okay. So again, let's drill down a little more into the types of biomechanical overload. And this is not an exhaustive list, but the types of things that can contribute to loss of myocytes, right? That's what happens in myocardial infarction. It can also happen via other myocyte loss mechanisms, things called apoptosis and processes like that, that are often downstream of inflammation as opposed to downstream of hyperperfusion. We can have volume overload. Stresses of the sort we might get with mitral regurgitation or aortic regurgitation or intracardiac shunts, and volume overload stress that tends to yield a more dilated myocardial chambered geometry. And that we also see increased afterload, right, that we might get with hypertension or aortic stenosis. And I'll also mention that left ventricular dilation itself causes increased afterload because of its effect on wall stress, and I'll have a slide about that in a moment. And then mechanical dyssynchrony, right? One area of myocardium getting activated relatively late and getting excessively preloaded by the early activated segments is another biomechanical overload mechanism, even though it originates from a separate source, usually conduction defects, but not always. Neurohormonal factors are also triggers of pathologic remodeling, and we'll discuss those in some depth in the slides ahead. Excess beta-adrenergic stimulation, excess renin-angiotensin system activation, vasopressin, natriuretic peptide decreases, which otherwise would tend to mitigate pathologic remodeling may also be a factor here. And then, as I highlighted, inflammatory cytokines as listed below. None of these things are exhaustive. These are exemplars of the different types of overloads or neurohormonal factors or cytokines, but they're not exhaustive. I will mention that the stuff in the top two clusters, their functional significance isn't just supported by preclinical data, but of course by clinical trials, and we target these things all the time. And I won't go into the specifics of that for this lecture, but it's pretty obvious. Okay, I do want to drill a little deeper, though, that increased hemodynamic load is a major driver of adverse cardiac remodeling. Many investigators, including myself, spend quite a bit of time modeling increased hemodynamic load and how it transduces changes in the cells and tissues of the heart. Certainly, the ones listed here are signature abnormalities. And I mentioned that cardiac dilatation, which unavoidably increases wall stress, especially if it's accompanied by wall thinning, is its own increased hemodynamic load. And so let's take a moment looking at that. Again, this should be familiar to folks that, of course, when we have an extrinsic afterload stress like aortic stenosis, as shown near the top here, that increases the systolic wall stress and in proportion to that increase in pressure. But also as the chamber, let's say the left ventricle dilates, we also see that that radius is directly proportional to wall stress. And if the ventricular wall thins at the same time, either as a result of myocardial infarction or just distending forces or cellular dropout, then that wall thickness is part of the denominator of wall stress. And so if the ventricular wall thins, that actually makes for higher afterload and increased ventricular wall stress. And that's not as quite as intuitive as the increase in pressure or reflected waves that also contribute to afterload, right? That the The aorta and the other major conduit arteries have a certain amount of elasticity, and they reflect back waves, and depending on the timing and intensity of those waves, that also is a source of afterload. So all of these are sources of increases in wall stress that you should be familiar with. Okay. So I mentioned dyssynchrony. I want to drill down a little bit more into it, although I suspect many of the viewers of this are familiar with it. The definition of left ventricular mechanical dyssynchrony is highlighted here: delayed contractile activation of some segments of the left ventricular myocardium compared with others. This is often downstream of conduction defects, electrical conduction defects, most prominently left bundle branch block. Although I've mentioned the contractile activation, you can actually have increased wall stress from diastolic factors, right? And independent of electrical dyssynchrony. So although left bundle branch block and conduction disorders are the most common causes of left ventricular mechanical dyssynchrony, you can have mechanical dyssynchrony without electrical dyssynchrony. There's various imaging modalities that I'll highlight on the next slide. And of course, this has great clinical relevance because it's a risk factor for adverse outcomes. It's not a rare cause of biomechanical overload dyssynchrony, that is, and early marker of myocardial disease in some cases, like a left bundle branch block and the associated dyssynchrony. And of course, it's a predictor of response to therapies like cardiac resynchronization therapy, or more recently, His bundle pacing and the like. This is a slide that I found from the citation shown at the bottom that's very nice about making the distinction between electrical versus mechanical dyssynchrony. In this top panel is ultra high frequency QRS analysis from two leads, whether it's V1 or V6. And with this ultra high frequency analysis, they can really detect activation sequences with greater detail and granularity, and demonstrate that in V1, picking up the septal activation more prominently, you see a much earlier activation in this individual with a left bundle branch block compared to V6, and you can quantitate this separation. And then with spectral tract echocardiography, STE, the readout is presented here on the bottom. And we can see that there's quite a bit of delay between the septal activation, which is in the upper part of these traces, and the lateral wall. So these are time on the x-axis and septum above lateral wall, and the activation is in red. And so at least shortening activation. And so the shortening activation occurs before in the septum, well before that in the LV free wall. And you can relate the electrical and mechanical. And again, as I mentioned on the previous slide, they need not be exactly in sync. You can have mechanical dyssynchrony without electrical dyssynchrony. That's important. I now want to, as we switch more towards neurohormonal mechanisms of remodeling, I want to remind that most of the things we see at the organ level are reflections of what's happening at the cellular level. And this is a pretty pair of pictures of cardiac myocytes. Again, cells get bigger with pathologic hypertrophy. So the number of cells in the myocardium changes quite little during life, except if we lose them, we don't really get more. But the way the hearts get much bigger is they get bigger cells. There's roughly 5 billion cardiomyocytes in a normal heart. Highlighting this, another one of these cartoons that show the different shapes of hearts. What I want to highlight is that as we're observing a thinned, dilated chamber at the myocyte level, there's increased myocyte length to a greater extent than myocyte width. We also may see changes in the non-myocyte cellular components of the heart, such as fibroblasts and that contribute to fibrosis, as I'll highlight later. There may be some dropout of cells from the increased stresses they're under, and we see a progression of cardiac dysfunction. Whereas the other pattern of pathologic hypertrophy, the concentric hypertrophy, if you look at the composite cells within that, the average myocyte length is increased, but the average myocyte width is increased to a greater extent. They have a thicker aspect ratio to individual cardiac myocytes, often with abnormal contractile kinetics, even if the fractional shortening isn't reduced. And these, again, from typical causes like hypertension, valve stenosis. And then I just want to take a moment to remind folks that you can have increased myocardial mass without it being pathologic. Athletes and women who are pregnant get a increase in myocardial mass, but the proportion of the myocytes is more or less intact. There's no fibrosis, there's no cardiac dysfunction, and no cellular dysfunction. So these are adaptive hypertrophy mechanisms that are quite distinct from the other two pathologic mechanisms. I want to highlight that neurohormonal activation in heart failure is quite prominent. It's not the first time people in this call have heard about it, but I want to highlight that in general, we can group them into large bins, that many of the ones that we have targeted to date are vasoconstricting sodium retaining systems like the renin-angiotensin-aldosterone system, sympathetic nervous system, vasopressin endothelin. There's also vasodilator natriuretic peptide systems that we more or less want to avoid antagonizing, maybe even potentiate if possible. And they're listed here: endogenous natriuretic peptides like ANP and BNP, native prostaglandins, kinins, and downstream of kinin signaling is nitric oxide. And again, these are, when people talk about neurohormonal activation, they're talking about these and systems like them. I want to mention that these systems, as I suspect many people know, are very protean in their actions. Even when we do something very precise, like give an ACE inhibitor or an angiotensin receptor antagonist, we're having quite a depending on the target tissue or cell. There's also a certain amount of crosstalk. This is a common theme, that when you have angiotensin 2, it actually increases sympathetic nervous system activity, and it affects vasopressin secretion. So in addition to target actions on the adrenal cortex or proximal tubule of the kidney or blood vessels causing vasoconstriction, you'll also activate other neurohormonal systems. So it's an amplifier effect. The adrenergic nervous system is similar in its many different actions, right? We'll see, again, just to take you through one of these cycles, right? You begin with a myocardial insult at the top. You may get some myocardial dysfunction that results in some decreased perfusion and maybe reduced oxygen delivery, but especially less loading of baroreceptors, which is a primary trigger for sympathetic nervous system activation. Or you could have activation via the renin-angiotensin system, as I just showed. This in turn will have a variety of consequences that sympathetic nervous system mediates. Changes in inotropy and chronotropy, and even relaxation. Initially, these are probably short-term adaptive responses to sympathetic stress, but in the longer term, we get less adaptive things like long-term sodium retention, vasoconstriction, worsened myocardial dysfunction from increased afterload, and you have the potential for some vicious cycles developing. And again, proven ultimately by therapies that inhibit sympathetic activation, proving to be beneficial for the trajectory of people with heart failure. Natriuretic peptide system biology, again, briefly summarized here. Usually it's hypertrophy leading to increased BNP or atrial distension leading to increased ANP secretion, many different actions, right? So even when we target one mediator, we get lots of effects. So that's what I'm trying to highlight here, that there may be antifibrotic effects. There's aldosterone inhibition, another example of crosstalk. We do, as the name suggests, natriuretic peptides promote natriuresis via both the direct effects on tubular portions of the kidney and by renin inhibition. There's also anti-proliferative effects of natriuretic peptides via their cyclic GMP second messengers and PKG signaling, and even some endothelin inhibition via ANP and BNP. So again, quite protein actions from a given peptide, and thus expected to have many actions or effects of inhibiting these peptides or potentiating them in the case of neprilysin inhibitors. And these result in coordinated effects, even though the target can be fairly precise. And again, one of the things I wanted to highlight is that the remodeled heart has many parallels at the organ level and the cell and tissue level, as summarized here. So for every increase in LV mass or LV dilatation or relative wall thinning, we see changes in the myocyte size and aspect ratio. Impaired contractility at the organ level is mirrored by impaired cellular shortening and slowed relaxation at the cellular level. And likewise, diastolic dysfunction or stiffness of the heart may be reflected or a reflection of increased fibrosis within the heart, and so on. Even the electrical abnormalities are reflected from changes in the electrophysiology and the reflective of changes in the electrophysiology and ion channel abnormalities within cardiac myocytes. I guess I want to bear that in mind, as in the coming slides, we'll delve a little deeper into the cardiomyocyte signaling processes. I'm including this slide purposely to scare you. We're not going to go over this. But hypertrophic signaling in cardiac myocytes are quite complex, and this by no means reflects all of them. So I want to try to help you come away with a more overview of how this happens. I tend to think of how cardiac myocyte remodeling occurs with a combination of three basic steps. There's pathologic triggers, there's molecular mediators, and there's phenotypic features that I just highlighted on the 2 slides ago, right? And so the type of pathologic triggers are the ones we mentioned at the beginning of this talk: genetics and host factors, hemodynamic load, neurohormonal stimulation, and comorbidities. The mediators we'll get to in a minute. And the phenotypic features are those I just highlighted on the previous slide. So the challenging part is those molecular mediators shown in very complex form on the previous slide. I put them in those mediators into 3 big bins here. One is there's receptors or mechanosensors or transducers, right? So these in one way sense and transduce, and these can be ligand receptors like beta-adrenergic receptor, angiotensin II receptor, or ion channels like TRPV channels. It can be integrins that are particularly good at regulating myocyte fibroblast interactions and mediating them. Sarcomeric proteins are also transducers, whether it's titin or microtubules or even cardiac myosin and F-actin, that these are mechanotransducers within the cell. Then there are those signaling pathways, those complicated things that were on that slide, and they are typically specific to individual upstream ligand receptors or ion channels, right? So the beta-adrenergic receptor triggers its signaling pathway, PKA, cyclic AMP dependent triggers. There are calcium-dependent signaling pathways like calcineurin or calcium kinase, calcium chem kinase, and downstream. Those are downstream of different receptors. There are MAP kinases. Inflammatory triggers often result in MAP kinase signaling, but biomechanical triggers can also invoke MAP kinase signaling. And there's protein kinase C as another signaling pathway that's downstream of angiotensin II or the alpha adrenergic receptor and endothelin-1, among other things. And then finally, once we get beyond the sensing the ligand or the mechanical stress or the inflammatory mediator, transducing it through the cell, we then have the transcriptional and protein regulators, things that affect gene expression or protein abundance or protein isoforms or protein post-translational modifications. And these act as switches to affect the cellular phenotype in the ways I've mentioned. And again, many things are listed here. I'm not going to read them all to you, but suffice to say they are a variety of different factors within the nucleus, and then some outside in the cytoplasm where we have a lot of protein modifications and microRNAs mediating effects throughout the cell. So this is just one example. We're not going to go into too much depth. Again, it begins with the beta-adrenergic receptor. That's the cell surface sensor. There's a transduction pathway in the middle, as highlighted here. In fact, there's several different transduction pathways. And then there's these responses within the nucleus that in turn produce cardiac hypertrophy or cardiac myocyte hypertrophy that in sum affects the whole myocardium. Among the transcriptional programs that are downstream of particular mediators or pathways are some that are actually part of normal fetal growth. There are isoforms that are typical of developing high growth circumstances in utero. And they differ by species sometimes, but they're listed here. And many of those change when we're adults. And so the isoforms that are prominent in the rapid growth of fetal development undergo transitions under these modulators in the postnatal state to produce different ones. And some of these get actually reactivated to the fetal forms in the setting of pathologic stress, like isoform switches of myosin. There's similar metabolic changes going on, right? So I'm not going to go through all the different fetal programs, but another one is where the switch to a fetal-like program has been well shown is for metabolic factors. So within both mitochondrial number or fuel metabolism proportions and contractile proteins, we see that there's a fetal gene protein reactivation in heart failure. So things that are active like predominance use of glucose and lactate in fetal hearts may get more activated in failing hearts and such. Same for the contractile protein isoforms, as I mentioned on the previous slide. On the other hand, cell cycle activity, which is quite active in fetal development, to our knowledge, never really becomes majorly active in the failing heart. Since I've mentioned metabolic remodeling, it's another facet of it that I'd like to highlight. The heart is often referred to as an omnivore. The cardiac myocytes are quite capable of using any one of a variety of different substrates highlighted here, especially in red, fatty acids, branched chain amino acids. They have typical percents shown in blue, as shown here. Many of these can feed into the TCA cycle and generate lots of ATP. In heart failure, there tends to be changes in the proportions of fuels used and burned to produce the contractility needs of the heart. So more ketone upregulation, but some downregulation of glucose utilization or other carbohydrate utilization, including lactate. And so we have less glucose being burned in the failing heart. And so that's another type of facet of remodeling. Since I've spent so much time talking about how signaling pathways affect the heart, I think it's at least worth giving a little bit of lip service to the fact that these same signaling pathways and neurohormonal systems, because they circulate, are capable of affecting other organs throughout the body. One, of course, is the kidney. That abnormal LV function produces sympathetic nervous system activation, non-osmotic AVP release, increased renin-angiotensin aldosterone system. And these have consequences like decreased renal perfusion and impaired sodium and water excretion from changes in tubular reabsorption and other factors. And so these are quite important effects of neurohormonal activation, less related directly to biomechanics, but more related to the neurohormones and sometimes cytokines. And we see things that we sometimes observe in our patients, things like hyponatremia, which are really the downstream consequences of that sodium retention and maybe water retention that exceeds the magnitude of the sodium retention, so-called total body sodium increase, but an even greater increase in total body water, producing dilutional hyponatremia, hypervolemic hyponatremia. And again, I want to at least give some lip service to the fact that inflammatory mediators of heart failure are getting more and more attention as potential targets for therapy. They come from different sources. They may be the endothelial cells that are throughout the myocardium, almost as numerous as the myocytes themselves, that monocytes and macrophages that reside within the myocardium, or other cells that traffic to the myocardium. They have their own inflammatory mediators highlighted here. Some are nitric oxide dependent, some are not. And they, in general, inflammatory mediators are not favorable agonists and tend to produce contractile dysfunction via both nitric oxide dependent and independent mechanisms. I want to finish up with a little bit about increased chamber stiffness. It's a feature of remodeling. One of the ways that we model it when we're looking at pressure volume loops with pressure on the y-axis, volume on the x, is ordinarily as the heart fills during this phase of the cardiac cycle. There's relatively little increase in pressure, but when a heart is stiffer, that same excursion produces a much increased slope of pressure increase as a function of volume, and that represents increased chamber stiffness. It's well established that there are extracellular contributors to increased chamber stiffness, things like fibrosis or collagen cross-linking that I'll mention a little more about in the next slide. We also know that abnormal protein deposition in the heart, things like infiltrative cardiomyopathies like amyloidosis, can increase the stiffness of the heart and lead to an increase in the left ventricular end diastolic pressure volume relationship. Also being recognized more and more is the fact that there are intracellular within cardiac myocyte sources of stiffness, not just the extracellular components. Things like titin, which has a spring-like function, and that spring constant of that spring-like function can vary with different post-translational modifications or other adaptations. Actin-myosin interactions can affect the diastolic distensibility of the heart. It's one of the things that is probably affected by mavacamten and other new therapeutics targeting cardiac myosin, and probably other sarcomeric elements will be targeted too in years to come. And microtubules, an area that I've been paying quite a bit of attention to lately, have post-translational modifications that result in changes in their biomechanical features of the microtubule network and affect intracellular stiffness, which in turn affects whole heart stiffness. It doesn't matter whether it's coming from the extracellular domain or the intracellular domain. It all affects the overall myocardial stiffness as reflected on pressure volume loops like this. Just a little more about fibroblasts and collagen, right? Collagen comes from activated fibroblasts that secrete collagen 1. It undergoes post-translational modifications, cleavage of the PICP fragment that results in something that can be measured in the circulation because it's a circulating marker of collagen synthesis. Meanwhile, another intervention or another change that happens with collagen once secreted is that can get cross-linked. That results in a greater stabilization of collagen, more resistance to degradation by things like matrix metalloproteinases. And so CITP is a marker of stabilized collagen such that we can relate the CITP to MMP1 ratio to the stability of and the degree of cross-linking of collagen. And it turns out that's of prognostic significance. And so these become important. A cross-linked collagen is more closely linked to myocardial stiffness than just total collagen. And we can measure that in the circulation or estimate that in the circulation. There's also some of the neurohormonal mediators may be able to mitigate that. Natriuretic peptides, again, activate cyclic GMP production in cardiac fibroblasts and inhibits collagen synthesis. So we see that activation of cyclic GMP in a dose-dependent manner by BNP, and that tends to be associated with less hydroxyproline, an anti-fibrotic effect. Hydroxyproline is a constituent of collagen. And again, these cytoskeleton proteins that I mentioned in the previous slide are shown in this cartoon. Actin and myosin are targets of new therapeutics and contribute to intramyocardial sources of stiffness. Titin, the giant protein that connects myosin to both the M band and the Z line, has different domains with different degrees of stiffness, and microtubules that I mentioned. These are all becoming targets of investigation for engagement as therapies. So let me summarize and finish here. A lot to cover. I realize I did it fast. The slides and the talk will be available for slower review. Pathologic cardiac remodeling following an initial triggering event is strongly linked to morbidity and mortality in both directions, both positive, pathologic remodeling and regression of pathologic remodeling. Hemodynamic overload, neurohormonal activation, and other patient-specific factors are major contributors to pathologic remodeling, as proven by the therapeutic benefit observed when these factors are mitigated. And it leads us to believe that as we address more of these, we may get other benefits. And then signaling pathways transducing biomechanical, neurohormonal, inflammatory processes prevent additional therapeutic opportunities with many emerging as therapeutic approaches that are targeting these mechanisms. So thank you all for your attention.
Well, thank you, Dr. Margulies, for a wonderful talk. Taking chapters and chapters from textbooks and putting it into 30 minutes of a presentation was not an easy task. Any questions from the group? Question I had, I think you kind of alluded to there at the end. I was curious to know where you thought targeted treatment options may be a possibility in regards to these different pathophysiological processes. You mentioned, the inflammatory processes, but I don't know if, with being so close to maybe this field, if you have any input on what may be coming down the line as far as like possible heart failure therapies based upon these
Yeah,
pathophysiological
you
principles?
know, we hear a lot about precision medicine, right? And of course, the leaders in that are cancer doctors, right? Because they have, everybody wants their cancer out, and we've been studying the molecular biology of tumors and the cells that comprise those tumors for much longer than we've had the opportunity to do that in the myocardium. And we still don't have nearly as many opportunities. And yet, we are really good with imaging and a variety of different imaging and phenotyping modalities that we use in everyday practice. And that as we learn to recognize biomarkers either from our imaging or circulating mediators, these will be opportunities for us to do our precision medicine, right? So one of the reasons I mentioned the circulating measures of collagen cross-linking, it may be the people who really will benefit from an antifibrotic therapy. Of course, we have ways like late gadolinium enhancement as looking at the global. So if we have evidence that there's quite a bit of fibrosis and it's very much stabilized, and we have some new therapeutic that can help reverse that. I was going to include a slide on CAR T cells from John Epstein and others about targeting fibrosis, and there may be a role for that. So I guess to answer your question in a generic way, as we use our existing and new tools to phenotype hearts for their mechanisms that are more predominant in some than others, just like cancer doctors look at molecular pathways that are more prominent in some cancers than others, I think we will have the opportunity to have better therapeutic index of, instead of one ACE inhibitor fits all, it happens every heart suffers when there's increased afterload. So targeting vasodilatation as one of our first therapeutics was a good move because none of them like that increased afterload. But as we want to get more precise, we're going to have to phenotype in a manner that gets us some insight into which pathologic processes are more prominent in a given patient's heart.
Exciting, and be very interested to see how this unfolds over the years to come. Well, thank you again, Dr. Margulies, for your time today. For everybody, thank you for joining us this afternoon, and have a great rest of your week.
Take care. Thanks for listening. Bye-bye.